state of Tennessee, they had to travel from Knoxville, remember, just to drive in, to dialyze. Some of them we could only dialyze a couple of times a week because they had to come so far. And so ultimately, I think it was the Kidney Foundation, maybe the health department in the state, and they say, would you consider putting a unit in Chattanooga and Knoxville and ultimately Jackson, Tennessee, those three areas. And we thought about it and we said, gee whiz, can we do this? And very carefully we explored it. And you know, Wendy Willingham, I don't know if that name rings a bell, over in Chattanooga, he was a urologist who said, we really need this in this community. There wasn't a nephrologist in town. So he bought into it. And then in Knoxville, there was a doctor there who was kind of hesitant to become involved, but ultimately he did. And in Jackson, Tennessee, I mean, that was really bare bones dialysis, but it, as you say, it got the job done. It may not have been fancy, but it got the job done. John was very concerned about the economics, you know, and we were really concerned about the patients. So, you know, naturally there's a little bit of a give and take there. And so we got some calls from various places out of town. So we said, you know, let's do it. You know, we either believe in this concept of not-for-profit dialysis and can talk about it, or we put, you know, our money basically where our mouth is and go help out Dr. Tuttle, because he really was, he certainly was motivated in the right direction. You know, that's the funny thing about it. I mean, nobody knew what the heck dialysis was. I mean, we joke about how did you get through your inspections when you started that unit, right? Yeah. Well, I mean, who would you call for an inspection and you talk about dialysis and they say, who, what? You know, so you just did it. So there was no inspection. There was no, and talk about certificate of need. If there was a certificate of need process, and I don't even know for those early units, I mean, heck, there was no unit in those areas when we went to those areas. So, and people were dying of kidney failure, so it wouldn't have taken a genius to figure out there was a need.
By 1981, there was a total of 21 clinics in the DCI system, with several in the works from Pennsylvania through Georgia and out to New Mexico.
What we need to be able to do is compare data, and we need a corporate medical information system. So it was really from our medical director meetings that the idea was originated. And so when we came back to Nashville, we put an ad, and I don't know who put the ad, but it was put in the Wall Street Journal. Why in the Wall Street Journal? I would. And who answers but Darwin Peterson, from Bowman Gray. And of course, Darwin came up to visit with us. His basic job at Bowman Gray was, I believe, as a professor of physiology, and he was a teacher there. But his sideline was in computer information, well, just computerism. And his idea, his concept behind working with the computer was that he wanted the computer to be functional to improve the care to be given to patients in our setting. So, I mean, he came up and blew our socks off with, you know, when we interviewed him. Well, you know Darwin, great guy, and a wonderful person, and a very competent person. And so he came on board with us, left Bowman Gray, moved to Nashville, and started the medical information system.
One of the unique things about this is that right from the start, we've intended this to, and designed it to be something that would fulfill our objectives, that would help us solve the problems that we have. I think we're just at the threshold of what's going to be a tremendous increase in the use of computers in clinical, in the care of clinical patients and in clinical research. How far we go with it depends to a great deal on what the individuals in the clinics want. I think there are a lot of benefits to being involved with it. One is that I'm convinced, as are others, that it's going to improve the quality of patient care simply because information will be more readily available.
It's nice to be able to take the data, share it with the docs, and then just step back and let everybody, instead of saying this is what the data shows, to put it out there and then to allow people to respond to it. And there have been many times where we thought we were going in one direction for care, and then we talked to the medical directors and we went in another direction, and it was a much better direction. So it's been such an incredible partnership. And without being able to base the discussion in data, we could not have been as successful as we've been.